Welcome back to the deep dive. Usually when we talk about the immune system on this show, we're telling a hero story.
Right.
It's the body's private security force, efficiently taking out viruses, warding off the flu, cleaning up debris. It's the good guy.
Absolutely. It's the Department of Defense working exactly as intended.
But today, we are flipping that script entirely. We are looking at what happens when that security force goes rogue, when the Defense Department turns its weapons inward and declares martial law on your own organs.
It is a civil war. That is really the only way to describe it. We are diving into inflammatory bowel disease, or IBD, and if you look at the medical literature, specifically the pharmacology text we have in front of us today, the language used to describe the pathology is, well, it's incredibly violent.
A battlefield.
It's a battlefield.
And it's a battlefield that affects millions of people. We're talking about ulcerative colitis and Crohn's disease. These aren't just, stomach aches. These are devastating chronic conditions where the body essentially tries to reject its own digestive tract.
Yeah.
But the pharmacology, the weapons we use to stop this civil war, is some of the most sophisticated science we have.
It really is. We're going to see everything from old school chemical engineering, literally using bacteria to detonate drug payloads, all the way to modern biologic warfare, where we design antibodies to hunt down specific proteins in the blood.
Okay, so let's set the stage for this deep dive. We have two heavy-hitting sources today. Who are our guides on this?
We are synthesizing two Bibles of pharmacology. First, we have Katzung's Basic and Clinical Pharmacology.
Katzung.
And Katzung is our strategist. It gives us the therapeutic pyramid, the rules of engagement. When do you use a sniper rifle? When do you call in an airstrike? It provides the clinical scaffolding.
Okay, the how and the second source.
That would be Goodman and Gilman's The Pharmacological Basis of Therapeutics. If Katzung is the general, Goodman and Gilman is the molecular engineer. It explains the why.
The deep mechanics.
It gets down into the receptor level, the cytokines, the kinases, the transcription factors. It provides that mechanistic depth.
And just a quick reminder to everyone listening, this is an interpretive synthesis. We are mapping out the concepts for you, but we aren't replacing the textbooks.
Not at all.
Use this as your guide, but you still got to read the chapter.
Absolutely. The text is the territory. We're just drawing the map.
Before we get lost in the chemistry, let's give the listener a roadmap. What are the big pillars we need to build today?
Okay, there are 5 key concepts.
Yeah.
If you zone out, come back for these.
Got it.
First is barrier breakdown. We need to understand that IBD isn't just an immune problem. It's a physical failure of the gut wall. The castle gates are broken.
Okay, broken gates.
Second is immune misalignment. We need to stop thinking of inflammation as one generic thing. The chemical signal for Crohn's is totally different from ulcerative colitis.
Yeah.
You can talk about Th1 versus Th2 versus Th17 cells. Specificity really matters.
Specific signals, right.
Third is the delivery problem. This is fascinating. I mean, how do you get a drug to the colon without it getting absorbed in the stomach? It's a huge logistical nightmare.
Smuggling the drug past customs.
Exactly. Fourth is the step-up logic. This is the strategy. Why do we start with weaker drugs and move to stronger ones? Or, controversially, should we do the opposite?
The escalation strategy.
And finally, targeted therapy and long-term thinking. How the new drugs, the biologics and small molecules, are changing the game by sniping specific targets rather than carpet bombing the whole body. And the vital distinction between inducing remission and maintaining it.
That is a massive agenda. Let's start at ground zero. The battlefield.
A battlefield. Let's do it.
We group ulcerative colitis and Crohn's disease together under this umbrella of IBD. But Goodman and Gilman makes it very clear. They are distinct entities. They are cousins, maybe, but they behave very, very differently.
Very differently. And understanding the anatomy of the disease is the only way to understand the drugs. Let's start with ulcerative colitis, or UC.
Give me the visual.
Okay, imagine a brush fire.
Yeah.
UC is a mucosal disease. That means it attacks the lining, the wallpaper of the colon. It doesn't usually burn through the wall. And crucially, it is confluent.
Confluent meaning continuous.
Yes. It starts at the rectum, the very end of the line, and marches backward, up the colon, without skipping a beat. It's a solid wall of flame, moving proximal.
And because it's stripping that lining, that's where the symptoms come from.
That's where you get the hallmark symptoms.
Yeah.
Bloody diarrhea, urgency, pain. I mean, it is raw, exposed tissue.
Okay, so UC is the continuous surface fire. Contrast that with Crohn's.
Crohn's is the heavy artillery. It doesn't just burn the wallpaper, it blows holes in the wall. It is transmural, meaning
Transmural.
the inflammation goes through the mucosa, the submucosa, the muscle, all the way to the serosa on the outside.
That sounds significantly more dangerous structurally.
It is. Because it goes so deep, you get complications that you rarely see in UC. You get fibrosis scar tissue that tightens up like a fist, blocking the intestine. Those are strictures.
Right.
Or you get fistulas.
Define a fistula for us. It's a word people hear, but what is it actually?
Think of it as an abnormal tunnel. The inflammation burrows all the way through the bowel wall and connects to something else. Wow. It might tunnel into another loop of intestine, or into the bladder, or even out through the skin. It's a leaking pipe burrowing through the body.
That is a terrifying image. And unlike UC, Crohn's isn't continuous, right?
Crohn's has skip lesions. You can have a patch of horrible ulcerated disease right next to a patch of perfectly healthy pink tissue.
So it's patchy.
And while UC is stuck in the colon, Crohn's can strike anywhere, from the mouth to the anus.
So UC is predictable geography, surface level. Crohn's is random geography, deep structural damage.
Precisely. And that dictates the treatment. If you have a fistula tunnel, you can't just treat the surface inflammation. You need powerful systemic drugs to close that tunnel.
Now, the million-dollar question, why? Why does the body suddenly decide to attack the gut?
This is where the science gets really interesting. The prevailing theory in both texts is a kind of three-hit model. You have genetics, the environment, and the microbiome.
Okay, let's break those down. Start with genetics. Is there an IBD gene?
Not just one. There are hundreds. But there's one that Goodman and Gilman highlights that is critical for understanding the mechanism, specifically in Crohn's, NOD2.
NOD2, what does it do?
In a healthy person, NOD2 is a sensor inside your immune cells. It recognizes bacterial cell walls, specifically a component called muramyl dipeptide.
So it's a lookout.
It's a lookout, and when it sees a bacteria, it triggers a process called autophagy.
Autophagy, self-eating.
Basically, it's the cell's waste disposal system. It wraps up the invading bacteria and destroys it. But in many Crohn's patients, the NOD2 gene is mutated. The sensor is broken.
So the bacteria aren't cleaned up.
Exactly. The bacteria linger. They invade. And because the first line of defense failed, the immune system panics and calls in the heavy airstrikes, the massive inflammation. So the inflammation is actually a compensation for a weak initial defense.
That's so ironic. The massive war is caused by a weak initial security guard.
It's a paradox. And this leads to the second hit, the microbiome. We call it dysbiosis.
We hear this word a lot in pop culture now. Heal your gut. But what does dysbiosis actually look like in the data?
It's not just bad bugs. It's a loss of diversity. In IBD patients, we see a collapse in the ecosystem. Specifically, we see a drop in the peacekeepers, bacteria like Faecalibacterium prosnitzi or Lactobacillus.
Peacekeepers?
These bacteria actually release anti-inflammatory chemicals.
They release peace treaties.
Pretty much. They release short-chain fatty acids like butyrate, which feed the gut lining and keep the immune system calm. In IBD, those guys die off.
And
the warmongers take over bacteria like invasive E. coli or Bacteroides.
So you have a genetic weakness, a shift in the bacterial population, and then the immune system just snaps.
And when it snaps, it releases the cytokines. This is our immune misalignment pillar. And this is crucial for you to grasp because every drug we talk about later targets one of these specific signals.
Okay, so Goodman and Gilman has that spaghetti diagram, figure 51:1. It's a mess of arrows. Help us untangle it.
Let's simplify it into two camps, Camp Crohn's and Camp UC.
Okay, Camp Crohn's first.
Crohn's disease is driven by a Th1 and a Th17 response.
Th1 and Th17, these are T helper cells.
Yes, they are the generals giving the orders. In Crohn's, the Th1 cell screams attack using a cytokine called interferon gamma and TNF-alpha.
TNF-alpha, that's the big target. We hear about that one a lot.
Huge target. Tumor necrosis factor. It recruits other immune cells to cause damage. But the new insight, the one that's changing pharmacology, is the Th17 cell.
Okay.
It pumps out interleukin-17 and interleukin-21. It recruits neutrophils, the suicide bombers of the immune system.
So in Crohn's, we have high TNF, high interferon, high IL-17. What about Camp UC?
Ulcerative colitis is a bit weirder. It looks more like a Th2 response. That involves interleukin-4, IL-4, and interleukin-13, IL-13. It involves natural killer T cells. It's a different flavor of inflammation.
And why does this distinction matter so much? Why can't we just use a generic anti-inflammatory?
Because specificity equals safety
Mm.
and efficacy. If I use a drug that blocks IL-12 and IL-23, which drive that Th1 pathway, it works wonders for Crohn's.
Right.
But it might not work as well for UC, or it might be less efficient. We are moving away from just dampening inflammation to snipping the specific wire that is ringing the alarm.
Okay, we've surveyed the battlefield. We see the broken wall, the bad bacteria, and the specific cytokine signals. Now let's open the armory.
Let's start with the infantry, the oldest, most widely used class for mild to moderate disease, the aminosalicylates, or 5-ASA.
5-ASA. And the prototype here is mesalamine.
Correct.
Now, looking at the chemical structure in Ketsung, this thing looks suspiciously like aspirin. Aspirin is acetyl salicylic acid. This is 5-aminosalicylic acid.
They are chemical siblings, absolutely.
So here's the obvious question. Aspirin is cheap. It's everywhere. Why can't an IBD patient just pop 2 aspirin and call it a day?
It's a great question. 2 reasons. First, aspirin is actually dangerous for IBD. It inhibits COX enzymes, which protect the stomach lining. Taking aspirin can actually trigger a flare.
Wow. Okay.
But the second reason is the delivery problem.
The delivery problem.
Imagine you have a fire in your living room, but you pour water on the roof. That's what taking plain 5-ASA is like. If you swallow unformulated 5-ASA, your stomach and your upper small intestine absorb 80% of it immediately.
It gets absorbed into the blood.
Right into the blood. Then it goes to the kidneys and you pee it out. It never reaches the colon.
And that's where the fire is.
And remember, UC is a disease of the colon surface. The drug needs to physically touch the inflamed tissue to work. It's a topical drug that works from the inside.
So it's like putting lotion on a rash, but the rash is inside your intestine.
Exactly. So if you swallow it and it disappears in the stomach, it's useless. The pharmacologist had to figure out a way to smuggle the drug through the acid bath of the stomach, through 20 feet of small intestine, and only release it when it hits the colon.
How on earth did they do that?
The first solution was sheer genius. It's a drug called sulfasalazine. This was developed back in the 1940s.
Okay.
They took the 5-ASA molecule and they chemically bonded it to a carrier molecule called sulfapyridine.
Bonded it how?
With an azo bond. That's a nitrogen double bond, NN.
Why is that bond special?
Because you and I, humans, don't have the enzyme to break it. We can't digest it. So when you swallow sulfasalazine, it travels through the stomach intact. Through the small intestine intact, it lands in the colon.
And who is waiting in the colon?
The bacteria, the microbiome. The bacteria have an enzyme called azoreductase. They attack that azo bond and slice it open.
That is incredible. So we are using the bacteria, the potential cause of the problem, to unlock the cure.
It's poetic, isn't it? The payload is detonated exactly where the bacteria live. The 5-ASA is released, coats the colon, and starts reducing inflammation.
Because a catch. Sulfasalazine isn't the gold standard anymore. Why not?
Because of the carrier. That sulfapyridine molecule. It's not just an inert taxi. Once it's cut loose, your body absorbs it. And it's nasty.
Nasty how?
It causes nausea, headaches, rashes. And in men, it can cause reversible infertility.
Infertility. That's a massive side effect.
It decreases sperm count and motility. It's fully reversible if you stop the drug. But for a young man wanting a family, that's a deal breaker.
Yeah.
Plus, some people are slow acetylators.
Slow acetylators. Explain that genetics concept.
Your liver processes that sulfa drug using an enzyme called N-acetyltransferase. Some people have a genetic variation where this enzyme works slowly. So the toxic sulfa drug builds up in their blood, leading to even worse side effects.
So we needed a better Trojan horse. One without the toxic taxi driver.
Enter the second generation 5-ASAs. The chemists got clever. They said, why do we need a toxic carrier? Why don't we just bond 2 5-ASA molecules together?
A twin molecule.
That's ulsalazine. 2 5-ASAs connected by that same azo bond. The bacteria cut it, and boom, you get a double dose of medicine and 0 toxic carrier.
That sounds perfect.
Almost. Turns out ulsalazine acts as a secretory agent in the small bowel. It causes diarrhea, which if you are an IBD patient is the last thing you need.
Right. Here's a drug for your diarrhea. It causes diarrhea. Not a great selling point.
Not at all. So the next iteration was pulsalizide. They went back to the carrier idea, but they used an inert, harmless carrier molecule that you just poop out. That works great.
Yeah.
But the most popular solution today is actually completely different. It doesn't use the bacterial bond at all. It uses pH-dependent coatings.
Like a smart show.
Exactly.
Okay.
We know that the pH of the gut changes as you go down. The stomach is highly acidic, like pH 1 or 2. The small intestine gets more neutral. The terminal ileum and colon are around pH 7.
So you make a pill that only dissolves at pH 7.
Precisely. That's drugs like Asacol or Lialda. They are coated in a resin that is impervious to acid. It stays solid until it hits that specific pH in the ileum or colon, and then pop it dissolves.
Katzung has this diagram, figure 62-8, that shows the release points. It's like a subway map of the gut.
It is, and this matters clinically. For example, a drug like Pentasa releases these tiny microspheres at a slightly lower pH, so it starts releasing in the small intestine.
Ah, so for Crohn's in the small bowel.
Exactly. Pentasa is a good choice. Acetol releases later. And if you have disease only in the rectum, oral drugs might not reach it at all.
Because the concentration drops off.
Right. If the fire's in the rectum, don't drop water from the roof. Use a hose. That's why we use suppositories or enemas. Mesalamine enemas are incredibly effective for distal disease because you are applying the drug directly to the burn.
Okay, so we've successfully delivered the 5-ASA. It's sitting on the inflamed tissue. What is it actually doing to the cells? You mentioned it's not blocking COX like aspirin.
This is the mechanism mystery. We know it works, but after 50 years, we are still arguing about how. Goodman and Gilman suggest it's a broad-spectrum dampener.
Dampening what?
Several things. First, it seems to inhibit the production of IL-1 and TNF-alpha. Second, it scavenges free radicals.
Free radicals being the oxidative stress molecules?
Yes. When neutrophils attack, they release reactive oxygen species to kill bacteria. But in IBD, they're just spraying that bleach onto your own tissue. 5-ASA mops that up. But the most elegant theory is that it interferes with NF-kappa B.
NF-kappa B. This is a term that comes up in almost every disease pathway.
It's the master switch.
Mm-hmm.
Imagine a protein inside the cell cytoplasm. It's normally locked up. But when an inflammatory signal hits the cell, NF-kappa B breaks free, marches into the nucleus, binds to the DNA, and turns on the war machine genes.
It's the launch codes.
It's the launch codes. And 5-ASA seems to jam the lock. It keeps NF-kappa B trapped in the cytoplasm. So even if the cell is screaming fire, the launch codes never get to the nucleus. The war machine doesn't turn on.
That is a powerful mechanism, jamming the signal at the source. But 5-ASA is the infantry. It's for mild to moderate cases.
Correct.
Sometimes the infantry gets overrun, the flare is severe, the patient is losing weight, anemic, in agony. We can't wait for a pH-coded pill to maybe jam a signal. We need to put the fire out now.
And that is where we cross the bridge. We move to the glucocorticoids.
Steroids, prednisone.
The double-edged sword of modern medicine. Katzung has a very strict rule about this. Steroids are for induction, not maintenance.
Explain that distinction. Why can't I just stay on prednisone? It makes me feel great.
Oh, it makes you feel like Superman for about 2 weeks. The energy returns, the pain vanishes, but the price you pay for long-term use is, well, it's essentially the dismantling of your body.
Dismantling.
It affects every organ system. It causes the Cushingoid features, moon face, buffalo hump. But deeper than that, it rots the bones. It inhibits osteoblasts, the bone builders, and stimulates osteoclasts, the bone eaters. You get osteoporosis.
Wow.
It causes diabetes by messing with glucose metabolism. It thins the skin. It causes cataracts.
So it puts out the fire in the gut, but it burns down the house.
That's a fair analogy. That's why we use it as a bridge. You use the steroids to stomp out the acute flare, and while you're doing that, you start safer, long-term drug like azathioprine or a biologic leave to take over.
So you cross the bridge from the flare side to the remission side.
Exactly. But the bridge is slippery. We have a phenomenon called steroid dependence. You try to lower the dose tapering from 40 milligrams to 30 milligrams to 20 milligrams, and boom, the symptoms come roaring back. The patient is stuck on the bridge.
And you can't live on the bridge.
You cannot. If a patient is steroid dependent, that is considered a treatment failure. You need to escalate to the top of the pyramid immediately.
Before we get to the top of the pyramid, is there a way to make steroids safer? We talked about the delivery systems for 5-ASA. Can we do the same for prednisone?
We can. And this is one of my favorite drugs to discuss because the pharmacokinetics are so clever. Budesonide.
The sniper.
The sniper. Budesonide is a potent steroid, actually more potent than hydrocortisone, but we exploit the first pass effect.
Walk us through the journey of a budesonide pill.
Okay. You swallow it. It's formulated, like the drug Entecort, to release in the ileum and right side of the colon classic Crohn's territory. It hits the tissue. It reduces inflammation locally. Then it gets absorbed into the bloodstream.
And where does all blood from the gut go first?
To the liver. The portal vein takes it straight to the liver. And the liver contains an enzyme called CYP3A4.
A cytochrome P450 enzyme. One of the big ones.
A huge one. The liver sees the budesonide and absolutely shreds it. It metabolizes about 90% of the drug into inactive metabolites before it ever reaches the rest of the body.
So the face, the bones, the skin, they barely see the drug.
They see about 10% of the dose. So the side effect profile is drastically lower. You rarely get the moon face or the bone loss
That's fantastic. Why don't we use it for everyone?
because it's not strong enough for the big fires. If you have severe pancolitis, meaning the whole colon is inflamed, or a massive flare, the 10% that slips through isn't enough, and the local effect might be overwhelmed.
So it's a specialized tool.
A specialized tool, not a nuke.
Okay. We've tried the infantry, 5-ASA. We've tried the fire department, steroids. But the war is still raging. Or maybe we want to prevent the war from ever restarting. We need to maintain the peace.
This brings us to the immunomodulators, the thiopurines, as a thioprine and 6-mercaptopurine, or 6-MP.
These are older drugs, right? Chemotherapy drugs.
Originally, yes. They are purine antimetabolites.
Break that down for us.
Your immune cells, your T cells and B cells, need to divide rapidly to sustain an attack. To divide, they need to make DNA. To make DNA, they need purines, which are adenine and guanine.
The building blocks.
Azathioprine is a fake building block. It looks like a purine, but when the cell tries to use it to build DNA, it acts like a wrench in the gears. It stops DNA replication.
So the cells can't divide?
The army can't recruit new soldiers.
So it starves the rebellion.
Slowly. That's the key point from Cat's-Own. Azathioprine takes weeks to months to work. You can be on it for 3 months before you see a benefit.
So it is useless for an acute flare.
Totally useless for putting out the fire. It is purely for keeping the fire out. It is a maintenance drug.
And there must be a catch.
There is a massive safety warning here that we have to discuss. It involves an enzyme called TPMT.
TPMT, thiopurine methyltransferase.
This enzyme is responsible for clearing the drug from your body. But here's the kicker. About 1 in 300 people have zero TPMT activity. They are genetically deficient.
What happens if you give azathioprine to one of those people?
The drug doesn't get broken down. It builds up to massive toxic levels.
Yeah.
It completely wipes out their bone marrow. No white cells, no red cells, no platelets. It can be fatal.
So you effectively kill their entire immune system.
Yes. That is why it is standard of care to test for TPMT activity before writing the prescription. If they have low activity, you lower the dose. If they have no activity, you cannot use the drug. Period.
This is really the era of personalized medicine. We are checking genes for the disease, like NOD2, and genes for the drug metabolism, like TPMT.
And we aren't done yet. Because even if azathioprine works, it has a slight increase in lymphoma risk. The trade-off is always there.
So if the infantry fails, the steroids are too toxic, and the immunomodulators are too slow or risky, what's left?
The Revolution, Part 4, the biologics.
This changed everything in the late 90s.
It saved intestines. Before infliximab, which is Remicade, if steroids failed, you went to the operating room. You got your colon cut out. Biologics gave us a medical option for severe disease.
Okay, let's focus on the first class, the anti-TNF agents. Infliximab, adalimumab, certolizumab.
We mentioned earlier that TNF-alpha is the loudmouth general in Crohn's disease. These drugs are monoclonal antibodies, Y-shaped proteins designed to grab TNF-alpha and take it out of circulation.
They just bind to it.
They bind to it with incredible affinity. They neutralize it. If TNF can't bind to its receptor, the inflammation signal stops cold.
But the structure of these antibodies is a history lesson in itself. Katzung makes a big deal about chimeric versus humanized.
It's a huge deal for the patient. Infliximab, the first one, is a chimera.
Like the Greek monster.
Exactly. A mix of species. It is 75% human, but the tips of the antibody, the claws that grab PNF, are 25% mouse.
Mouse protein.
Mouse protein. And the human immune system is smart. It looks at that mouse protein and says, that's not us. So the patient can develop anti-drug antibodies, or ADAs.
Wait, so the immune system attacks the drug that is trying to stop the immune system?
It's meta-warfare.
Mm-hmm.
Your body creates antibodies against the antibody. This does two things. One, it neutralizes the drug so it stops working. It's called secondary loss of response.
Right.
Two, it can cause an allergic reaction, an infusion reaction.
How do we fix that?
We made the drugs more human. Adalimumab, or Humira, is 100% human. No mouse parts. The body is much less likely to attack it.
Less likely, but not impossible.
Not impossible. It still happens. That's why we sometimes do combination therapy. Remember azathioprine?
The slow maintenance drug.
Sometimes we give azathioprine with infliximab, not just for the double anti-inflammatory effect, but because the azathioprine suppresses the body's ability to make antibodies against the infliximab. It's a bodyguard for the biologic.
That is strategic brilliance. But blocking TNF comes with terrifying baggage.
Tuberculosis.
This is the most critical safety warning in the entire chapter. Why do we have TNF? We didn't evolve it to cause Crohn's. We evolved it to fight intracellular bacteria like TB. It builds the wall, right? The granuloma.
Exactly. If you inhale TB, your body often can't kill it. So TNF organizes a granuloma, a prison cell made of immune cells, to wall off the bacteria. You might live with latent TB for 50 years.
The TB is asleep in the prison.
Until you take infliximab. You take the drug. You remove the TNF. The prison walls dissolve. The TB wakes up, and it disseminates. It can kill the patient rapidly.
So you must test.
You must test for latent TB with a PPD or a quantiferum gold test before starting. If they're positive, you have to treat the TB first. No exceptions.
Okay, so anti-TNF is powerful but risky. Let's move to the next class. Anti-integrins, vedolizumab. You use the metaphor of traffic control for this.
If anti-TNF is silencing the generals, anti-integrin is closing the borders.
How does that work?
White blood cells, specifically leukocytes, float around in the blood. To cause inflammation in the gut, they have to exit the blood vessel and enter the tissue. To do that, they need an ID badge.
An ID badge.
That badge is a protein on their surface called an integrin. The blood vessel wall has a scanner called a selectin or a CAM. If the badge matches the scanner, the door opens and the white blood cell rushes in.
So vedolizumab blocks the scanner.
It blocks the badge, specifically the alpha-4 beta-7 integrin.
Alpha-4 beta-7. Why is that specific sequence so important?
This is the beauty of targeted therapy. That specific integrin is only used for the gut. It's a gut-exclusive pass.
Oh, wow.
So vedolizumab locks the doors to the intestine, but allows white blood cells to go everywhere else, to the lungs, the skin, the brain.
That is huge for safety because there was an older drug, nolizumab, that wasn't so picky.
Vedolizumab was a tragedy in some ways. It blocked the alpha-4 integrin on Gerald Pass. It stopped inflammation in the gut, yes, but it also stopped white blood cells from entering the brain.
And the brain needs protection, too.
It does. By blocking entry to the brain, it allowed a dormant virus, the JC virus, to wake up and cause PML, progressive multifocal leukoencephalopathy.
And that is?
It's a horrific, fatal brain infection. That's why vedolizumab is so preferred now. It spares the brain.
Amazing. Science learning from its mistakes. Let's talk about the next step in biologics. The anti-IL-12/23 drugs. Ustekinumab.
Ustekinumab targets the command chain even higher up than TNF. It binds to the P40 subunit.
The P40 subunit.
It's a protein part shared by both interleukin-12 and interleukin-23. By binding this one piece, you take out two major cytokine pathways at once.
Oh, that's efficient.
And you prevent the differentiation of those Th1 and Th17 cells we talked about earlier.
So you stop the army from even being recruited.
Exactly. It's effective, especially for Crohn's patients who have already failed anti-TNF therapy. It's another option in the toolkit.
And finally, the new kids on the block. The small molecules, JAK inhibitors like tafasitamab.
These are different. All the biologics we just discussed, infliximab, vedolizumab, ustekinumab, are huge proteins. They're antibodies. They work outside the cell. They float in the blood and catch things.
And tafasitamab.
It's a small molecule. It's tiny. It can slip right through the cell membrane and go inside the cell. It works on the JAK-STAT pathway.
Which is inside the cell.
Yes. Think of the cytokine as the person ringing the doorbell. The biologic stops the finger from pressing the button. The JAK inhibitor cuts the wire inside the house so the bell doesn't ring, even if the button is pressed. It interrupts the signal transduction from the surface to the nucleus.
That's a great image, cutting the wire inside the house.
And because it's a small molecule, you can take it as a pill. No injections, no infusions. That is a huge quality of life improvement for patients.
Okay, we have an arsenal. Infantry, fire extinguishers, snipers, traffic control, and wire cutters. How does a doctor choose? This brings us to part 5, clinical strategy.
We use the therapeutic pyramid. Visualize a pyramid.
Got it.
At the base, you have mild disease. You use the safest, cheapest drugs. 5 ASA, maybe some antibiotics, maybe topical steroids.
Low risk, moderate reward.
Right. If that fails, or if the disease is moderate, you move up the middle. You use oral steroids to induce remission, and then immunomodulators like ethioprine to maintain it.
And at the tip of the pyramid?
Severe disease. That's where the biologics live. And finally, surgery.
This is the step-up approach. Start low, go high. But is that always the best way?
That is the big debate in the field right now. There is a counter-argument called top-down.
Hit hard and fast.
Exactly.
Yeah.
If you have a patient with high-risk features, deep ulcers, young age, bad genetics, why wait? While you are messing around with 5 ASA, the disease is tunneling through the wall, causing strictures and fistulas. The damage is permanent.
So top-down says, use the biologics first to prevent the scarring.
Save the gut while you can. It's aggressive, but it might change the long-term trajectory of the disease.
Let's apply this to a real human being. Katsung has a case study. A 21-year-old woman. She has Crohn's in the ileum and proximal colon. She was on mesalamine and butzenide, but now she's relapsing, losing weight, anemia, pain.
This is a classic failure of the base scenario. She's on the bottom of the pyramid. Mesalamine, as we discussed, has questionable efficacy in Crohn's. It's mostly for UC.
Right.
And butzenide is the sniper, good for mild cases, but she's having a major flare.
So the sniper and the infantry aren't holding the line.
No. She needs a reset. The Katsum solution is twofold. First, put out the fire. She needs systemic steroids, prednisone tapered over 8 to 12 weeks. Butzenide isn't cutting it. She needs the heavy extinguisher to stop the weight loss and inflammation now.
But she can't stay on prednisone forever.
Right. So simultaneously, you start a maintenance strategy. You might add azathioprine, or more likely in modern practice, you step her up to an anti-TNF like infliximab or adalimumab.
And the goal here isn't just to make her feel better, is it? It's about something called mucosal healing.
Crucial concept. It's not enough for the patient to say, I have no pain. We need to put a camera in there and see that the ulcers are gone. Because if the ulcers are still there, the fire is still smoldering, and the complications will come back.
Before we wrap up, we have to mention the microbiome one last time. If dysbiosis is a cause, can't we just fix the bacteria? Antibiotics, probiotics.
It's surprisingly difficult. We use antibiotics like metronidazole or ciprofloxacin, especially for Crohn's disease around the anus, what we call perianal disease. They help reduce the bacterial load, the antigenic load.
But they don't fix the underlying imbalance permanently.
No. And probiotics have been, frankly, disappointing in most clinical trials. It seems it's much easier to destroy an ecosystem than to rebuild one. We are still in the very early days of microbiome manipulation.
So we've covered the battlefield, the weapons, and the strategy. We've seen how 5-ASA explodes in the colon, how steroids bridge the gap, and how biologics hunt down cytokines.
We've traveled from the chemical azole bond all the way to the latest humanized monoclonal antibody. It's an amazing journey.
What's the final thought here? What should the listener be thinking about as they close this deep dive?
I want to leave you with a provocation. Look at everything we discussed today. Anti-TNF, anti-integrin, JK inhibitors, steroids. What do they all have in common?
They all stop the immune system. They are suppressive.
Exactly. We are getting incredibly good at suppressing the attack. We have moved from shotguns to sniper rifles. But we are still just stopping the defense mechanism. We aren't fixing the barrier. We aren't fixing the dysbiosis.
We're stopping the civil war, but we aren't rebuilding the nation.
Precisely. The future of pharmacology in IBD might not be in better suppression. It might be in mucosal healing, actually regrowing the wall, or in permanently altering the microbiome landscape. That is the next frontier. Not just stopping the damage, but restoring the peace.
That is a fascinating place to stop. For everyone listening, your mission now is to open the books. Go to Katsung Chapter 62 and stare at that therapeutic pyramid. Ask yourself why each drug sits where it sits.
And open Goodman and Gilman Chapter 51. Trace the lines in Figure 51:1. Follow the cytokines. The podcast is the map, but the text is the territory.
Thanks for diving deep with us. We'll see you on the next one.
Take care.